OK。見えてる？見てますか？ Good morning, everyone. いけてる？ It's okay. It's okay. Okay, can you see my slide? Okay, I'll continue my talk about kinematic alignment. In the kinematic alignment, basically the aim of this procedure is to replicate the patient native arterial surface using the component implants. So, furthermore, the components should be implanted along the three kinematic axes. One is the flexion axis of the tibia, is the green one, and the flexion axis of the patella, that is describing the purple line, and tibial longitudinal rotation axis, that is a yellow line, so-called medial pivotal motion. So, the following this concept, so this is the medial pivot design, PK, is ideal. And similar to the simulating the posterior condyle shape, so single radius component is ideal for it. So this is the leader of kinematic alignment component. It is the metacuta. Metacuta has the medial side, perfect conformity, media size, so-called a kind of boring socket articulation. The lateral side is flat. So around the media side, the lateral condyle can move anteriorly, posteriorly freely. So this is the idea. But most manufacturer provides the similar component. For example, Zimmer Biomet provides MC component. That is the same concept. On the media side, the high conformity, lateral side has less conformity, are relatively free to move anteriorly and posteriorly. So basically, this is a calibrated kinematic alignment technique that is quite simple. We never mind the total alignment, ligament balance. We are just looking the articular surface, just looking at the bony landmark. So the first three cut distal femur are the same thickness as the component. If the patient has a normal coverage on the both sides, medial side and the lateral side, it is quite simple cut. Only the same thickness, mostly maybe 9 millimeter, the medial side 9 millimeter, lateral side 5 millimeter. But in most cases, in the osteoarthritis case, the patient has at least one component, cartilage is already worn out. So we need to compensate for the cartilage loss. The normal patient's cartilage thickness is around 2 millimeters. So if the patient had medial osteoarthritis, we need to cut 2 millimeter thinner than the affected lateral side. So lateral, so eventually lateral side should be the 9 millimeter and medial side should be the 7 millimeter. Plus one cartilage thickness as 2 millimeter. And this is the famous. So this is the special designed paddle. So it's the part is 2 millimeter thicker on the medial side. So then push the paddle on the distal end of femur, then connect to the distal cutting block. Then lateral side can be cut in 9 millimeter and medial side cut in the 7 millimeter. Then move on to the posterior cut. In the kinematic alignment, the femur side cut is completed before the tibia cutting. So thematic alignment is a femur-driven technique. So finalize the femur side, then move on to the tibia side. So after the distal cut, the posterior should be cut in the same thickness. In the most osteoarthritis patient, posterior cartilage remains normal or nearly normal. In this situation, the distal cut should be same on the medial side and the lateral side. Normally 9 or 8 millimeter. It depends on the design of the component. And for example, the biomet has a component with 9 millimeter thickness of the posterior condyle and 8 millimeter thickness of 4 millimeter DMK. And that is different among the components, but basically in the same thickness. Eventually, this rotation angle should be the 0. In the mechanical alignment concept, most surgeons select 3 degrees external rotated or between 3 to 5 degrees in the external rotated. It depends on the difference between the transepicondyle axis and posterior condylar axis. Anyway, so just cutting the same thickness in the posterior and the lateral. So distal side cut the same thickness and posterior cut thickness, then the pre-operative articular surface can be restored using the family component. And distal the tibia side, they cut the same thickness as, again, they cut the same thickness as the component. In the most component, the thinnest polyethylene insert plus tibia component thickness should be the 10 millimeter, or some component have the 9 millimeter. It depends on the design of component, again, similar to the femur side. For example, so femur biomet, I'm a Persona user, so Persona, the thickness, polyethylene thickness is 10 millimeter. So cut the lateral side in the 10 millimeter thickness, and the medial side in 8 millimeter, because of the 2 millimeter thickness of cartilage wear. Okay, so for this purpose, so use the 2 double stylus. One is for the lateral side, another is for medial side. So, and anyway, cut the parallel to the native, following the native slope of the medial side, and at the same time, the posterior slope should be the same as the previous one. So that's all. It's quite simple. We never mind the alignment, and ligament balance. So eventually, if you replicate the pre-disease arterial surface using the component, the patient constitutional alignment and patient natural ligament balance, it should be restored. So because in the pre-disease condition, is everything is harmonized. So ligament balance, ligament and morphology, bone surface is makes a good combination. So do you know the 4-bar linkage theory? Do you know the 4-bar linkage theory? If we decide PCL, ACL, and the patella, then we move, so shape of the femur condyle can be restored. So it implies that ligament balancing and the morphology of the femur and the tibia is best match combination 1 by 1. So in the same theory, if we replicate the articular surface perfectly the eventual ligament balance should be harmonized. Okay. But after the kinematic alignment, the component is implanted a slightly better alignment, and the total leg alignment should be slightly better alignment. This is similar to the patient native alignment. So sometimes that kind of X-ray disappoint the surgeon because the AMA component is the varus implanted tibia component is the implies the patient the surgeon lack of skill. But it's okay. It's okay. No problems. Or if you use the kinematic alignment concept. But it is sometimes it will conflict if this patient move on to the GP. Most all GP consider this is the bad operation because of the varus alignment. So I have to yes explain the concept of kinematic alignment. Anyway, so this is the same as the concept of UK. The concept of the UK is just restore the patient native alignment, or it is depend on the length of thickness of MCL. So restore pre-disease function. This is the same concept. Never reconstruct the knee to the ideal condition. So-called mechanical alignment. So the straight leg and the perpendicular joint surface. Okay. So using the restoring the pre-arthritic alignment, this slide have been already shown in the previously. Similar to the Oxford, after the kinematic alignment, PA-TKA, the jaw leg alignment should be restored pretty one. But some question is arises. Why is the organ jaw fine with the patient with the bony defects? If we think there is no bone loss, it is quite easy to 10 millimeter and 8 millimeter is enough, but obviously the patient had bone side. What we cannot estimate the thickness of the bone loss. So how to estimate the bone loss it is a very big problem. But my opinion, not only the tibia side, but also the femur side has the bone loss, some amount of bone loss, but no one can estimate the amount of bone loss in terms of regarding the femur side. This is a problem. My next interest how to estimate the femur bone loss and how to compensate for such kind of bone loss. Even if we can know the patient's native constitutional alignment, if the patient has the extreme alignments such as so-called constitutional alignment, 3 degrees or more in the balance of HKA, can we naively replicate the patient native alignment? It's not so extreme. The alignment is considered to cause some failure such as loosening. So this is a question. May I have a time?